Good morning. Happy Wednesday, everybody. We've made it in the home stretch of this class. My name is Jim Sullivan. I'm going to talk to you a little bit about healthcare inequities in the emergency setting. So why is healthcare, or what is healthcare inequity? So it's a systematic difference in health that could be avoided by reasonable means. The Secretary's Advisory Committee for Healthy People 2030 recommended that achieving health equity requires eliminating avoidable, unjust, unfair health inequities and health disparities through short and long-term actions. So why is this important to us? It's so patients receive quality health care in an easily accessible and cost-effective manner. So healthcare in rural America is the population I've chosen to really look at. Rural America has unique challenges, not only in just daily life, but in healthcare in general. They have limited access to healthcare facilities and providers. We see that they have lack of insurance in many instances because these patients usually, or many times in rural America, they have farming jobs or they have jobs that don't provide any type of insurance because it's such a small area and there's very limited resources. And there's digital and technology deficiencies that we see. We haven't done a very good job at caring for these patients. So 21% of Americans live in the rural area, but less than 10% of physicians practice in that area. So we've got some catching up to do. For the emergency setting, patients that live in rural areas use the emergency department for their primary care, and many of these patients have not seen doctors in years. What this means is by the time they come to the hospital to be seen, many times they're in very late stages of their diagnosis, such as cancer, congestive heart failure, end-stage renal disease, and all that just leads up to a shortened life expectancy because they haven't gotten preventative treatment early on. Many of these rural patients will utilize the emergency department for symptom management. That leads to increased wait times in the ER. That also leads to increase in waiting for an inpatient bed to become available, unnecessary tests and treatment to be done that aren't really going to extend their life expectancy, and then increased risk of having readmissions to the facility. So what I wanted to show here on this slide was just barriers to accessing healthcare. We've talked about most of these things, if not all these things, throughout this class. We see that all these things are interrelated. They overlap and they're very multifaceted. So the things that can really be a barrier to achieving healthcare are insurance, affordability, social determinants, not just one, but sometimes there's many. There's issues with paying for prescriptions. There's issues with paying utilities. There's food insecurities. We also see technical literacy as a problem, communication gaps between the patient and the provider, along with information sharing. And that can even be provider to provider, provider to healthcare system, and then, like I said, provider to patient. This leads to high out-of-pocket costs for patients. Racism can play a factor in this, and provider availability, and then lack of appointments to be seen is a huge barrier. So let's do a case study. So DG is a 79-year-old male who was recently widowed with 4 adult grown children. He lives alone on 100 acres in rural America. It's in a rural area of Texas, actually. And his nearest adult child lives about 15 miles away. His other 3 children, one lives out of state, and the other 2 live a little further out, but they're not really far. They just don't live real close by to him. His primary income is from selling wood in the wintertime, and they also have a cattle ranch. He lives in a town of about 700 people, so very, very small. And he has a history of having a heart attack about 5 years ago and type 2 diabetes. So let's look at his access to health care. his nearest medical facility is about 20 miles away from his home. The medical facility is a small critical access hospital. It stabilizes and then transfers patients to higher level of care. And the hospital in their system that they transferred to is about 90 to 100 miles away. There was a very small clinic in his hometown that he used to go to be treated, but due to budget cuts and funding from local healthcare system, that clinic has since closed up. He had no insurance, being he was self-employed his whole life. His wife did work, and she had a small health insurance policy that helped a little bit, but when she passed away several months ago, his health insurance benefits stopped. He has since been able to get some assistance with Medicaid, and he's in the process of trying to get some Medicare benefits from his wife, but that's still in the works. But he does have a little bit of coverage that one of the healthcare facilities helped him arrange. One important factor for him, though, is he has no cell phone service or internet on his property. He lives so far out, there's nothing really there. So all of these things create inequities in healthcare for him. So access to healthcare in rural America has, like I say, its own challenges, but one of the big ones is just limited access to healthcare. We just saw in that case study that his medical facility is about 20 miles away, but his larger one where he is usually seen at is over 100 miles away. If he's seen at the hospital that's near him, anything that's very serious, again, he's going to be transferred out. We also see that there's provider shortages in healthcare in rural America, and the distance time it takes to travel to these facilities is a huge factor. Like I said, his hometown clinic has closed up, which has caused provider shortages. The time it takes for him to travel over 90 miles to be seen by his cardiologist is another important factor. His primary care physician does come to that hospital that's near his home about 2 times a month, and that's who treats him for his diabetes. There again, appointments are few, and he's only there twice a month, so he's trying to see all his patients at one time, which causes a lot of issues with trying to get appointments and trying to be seen and follow up. The slide shows here increased risk of death with cancer patients. So for colon cancer patients, there is an estimated 8 to 15% increased risk of death. And then in lung cancer, there's up to 20% higher rates of death than in metropolitan areas. So this is due to rural patients more likely to be diagnosed in later stages of healthcare, and they just don't have the means for appropriate follow-up with a specialist. So with quality of healthcare in rural America, care is often fragmented. There's no local healthcare facilities available, and internet and cell phone service is a problem. So DG does use the urgent care for minor complaints and has used the emergency department for more serious complaints. However, they're on different electronic health records than the facility that his cardiologist uses. This creates fragmented and poor quality care since the providers do not have any kind of access to his medical records. Like I said, he does have no internet in his home, so that makes telehealth impossible. He has no access to cell phone service to make appointments, send chat messages to his providers, or access his medical records via a system app. He does have a cell phone that he takes with him when he leaves home for emergencies, but he's very limited in what he can do with that phone, and his knowledge of really what the phone can do is really significantly less. Cost of healthcare in rural areas, we see low income and no employment benefits many times, higher uninsured rate, and time off work can be an issue. Many times, like in this case with DG, if he doesn't work, he doesn't get paid. So DG has no employment benefits for most of his life. He now is receiving some benefits like I talked about, which is helping to offset some of the cost of medical bills and medications, but not everything. When DG does go to see his PCP or a specialist, he has to take time off work, which means no pay for that day. And the last time he went to the emergency department, he was transferred to the other facility, which meant that he had 2 emergency bills. He had the cost of being transferred, time off work, and then he incurred bills for costly tests and treatments that were just things that could have been preventative had he had health care sooner. So these statistics and the Affordable Care Act, I just kind of wanted to just highlight. And something that I read from Buchmuller stated that the reform for private insurance, the creation of new source of affordable health insurance through the marketplace and the expansion of Medicaid has led to a significant increase in insurance coverage. The uninsured rate fell substantially between 2013 and 2016. So in 2013, we were about 14.4%, and in 2016, we were at 9%. And you can see on the left-hand slide there that sharp decrease that you see on the uninsured rate. What that meant was Medicaid enrollment did increase. So in 2014, we were about 10.8 million people that had Medicaid. In 2015, that increased to 12.2. So you can see that on the right side with that steep incline. So potential improvements to reduce inequities are through health policy. And policy really focused on improving access to health care through insurance coverage, such as the Affordable Care Act, that Medicaid expansion, and those have both led to better health and reduced mortality in this patient population. So improvements for better care. So to achieve optimal health for everyone, social determinants of health and barriers to care must be addressed. Improved access to health care will not be enough. So factors to improve outcomes can include location, health literacy, access to information, and expanding Medicaid and private insurance benefits. Working with government agencies to incentivize providers to practice in rural areas, maybe at least once a week or maybe even 2 times a month, would improve access to care and improve coordination of care. Incentivizing healthcare systems to keep clinics open in small towns by giving tax cuts would be a huge help in getting patients in rural areas primary care, if nothing else. And then working with cell phone carriers to improve internet, cell phone reception in rural areas. Those need to be addressed so patients have reliable cell phone service and they can access their healthcare apps, make appointments easier, and have access to telehealth, which is all greatly needed in this population. Incentives for healthcare system to expand services to smaller towns would assist this patient population in having access to quality care, again, like I said. And then extending hours for clinics so patients don't have to take time off work is another benefit. Maybe the clinic stays open one night a week late, or maybe they open on Saturday 1 time a month. So anything is better than nothing. Improvements in accessibility, quality, and cost control will afford every person the right to health and well-being. Again, policies and interventions must consider all these barriers, eliminate disparities in healthcare, and then through partnerships with government agencies, healthcare systems, and the community, that's going to lead us in the right direction in improving the health of our rural patients so they receive quality care in a cost-effective and timely manner. So I want to thank you for taking time to listen. I look forward to questions and comments, and have a great day. Thanks.